Hello everyone, we're going to do a quick anatomy review of our somatosensory evoked potentials. We want to look at the nerves and the bones, the landmarks that we have to know in order to run this test correctly. So we're going to use this cool 3D anatomy software so that we can visualize the nerves and the bones and find them when we're in the operating room on a real patient. So let's isolate the left leg and zoom on in down to the foot and find our posterior tibial nerve right here. And so this is the nerve that we use most often. It has this nice curvature that I like to describe of like a hockey stick. And what we're going to use to find it is our malleolus, this bony protuberance at the bottom of our tibia. And if we turn the foot to the side, we can see it kind of juts out, and this is what we use to feel. If you feel for this malleolus on the inside of your ankle, you know that the nerve is just behind it, the posterior tibial nerve. Now when we stimulate, we have two electrodes. We have our positive anode and our negative cathode, and we're going to place them in this orientation with the cathode placed proximally and the anode placed distally. This causes the flow of electricity to go from the cathode to the anode, which then causes our current to go in the other direction, up the nerve, up the spine, all the way up to the brain. This is how it works in the normal way. So let's continue following the path of this nerve as it travels up. And let's isolate it. So we can see it travels up the back of the leg, up past the ankle to the back of the knee, the popliteal fossa, right here. And it continues to travel up where it joins up here with the sciatic nerve. And the sciatic nerve is a very large multi-branched lumbar nerve. And we can see it here as it enters into the spine. We see our lowest lumbar vertebra, our L5, our L4, and our sacral bones, and in between the nerves as they come out. So now you might not always be able to stimulate down here at the ankle. It's not always possible. Sometimes you have a patient who's got a very swollen ankle, or if they've been amputated, if they have diabetic neuropathies, it's not always possible to get a signal from down here at the ankle. In that case, what you want to do is follow the nerve, and we can stimulate here at the popliteal fossa. If you have recording electrodes here at the popliteal fossa, you can just repurpose them. You can unplug them from your recording unit and plug them into your stimulation unit. And then you want to make sure you have your electrodes in the same orientation as down at the ankle, with your negative cathode placed proximally and your positive anode placed distally. The other option that we have is we can follow that nerve, and we see here it branches into the sciatic nerve, but we also have another branch known as the common fibular nerve or the peroneal nerve. And so let's follow this nerve down, and we use this, the fibular head, the very top of the fibula, to find the nerve. So you can feel this if you feel the outside of the area just below your knee. And we're going to take our electrodes and we're going to do the exact same thing. We're going to have our negative electrode placed proximally and our positive electrode placed distally. So these are the three options that we have. Most common is down at the ankle, and then the peroneal nerve, or the popliteal fossa. These are our options for our lower extremity stimulation.